To continue to talk a little bit about oxytocin, we did talk that it can be used to induce or augment labor. Normally, oxytocin is a hormone that is produced in the posterior pituitary gland, and so when a woman becomes ready for labor and delivery, her posterior pituitary starts to secrete oxytocin. The maternal hazards of pitocin are listed out up here as far as the uterine rupture. It could also cause placental abruption and needs for unnecessary C-section. The fetal hazards include hypoxemia and acidemia with decreased placental perfusion due to tachysystole. So when we are administering oxytocin, we want to make sure that we are administering it through a secondary port, that it's piggybacked into your mainline IV, and rather than like a piggyback medication, we are going to piggyback oxytocin into the lowest port, because you don't want to have oxytocin at the highest port and then have all the rest of the oxytocin infused down through that port if you have piggybacked into the highest port like a typical normal IV piggyback medication. So if you are ever running oxytocin, make sure you're piggybacking that with primary tubing into the lowest port. Again, continuous fetal monitoring, so we want to be looking at blood pressure of mom every 30 to 60 minutes, and then fetal heart tones every 15 minutes. And then any time that you change your pitocin rate, you do need to document fetal heart rate, and then uterine contractions every 15 minutes. And make sure that you always document a resting tone so that we're ensuring that she has not lost that resting tone. Augmentation of labor works much the same way, again with pitocin. As far as invasive, if you are utilizing pitocin, you want to make sure that, again, the piggybacking to the lowest port, those types of things. With an amniotomy, the physician will perform a rupture of membranes, and then really from there, there's not much more we do after an amniotomy. Non-invasive things, so if your mom is having maybe some irregular contractions, have her get up, have her use the restroom, have her walk in the hallway, have her get up on the birthing ball. Just lots of different things, up in the shower, making sure that she has adequate fluid intake, those such things. Nursing interventions, if you have a patient just coming in for an induction or augmentation, lots of different things are listed out up here. So again, you want to reflect back to that nursing admission assessment. Continuous fetal monitoring while you're waiting your physician. So one thing I typically have the moms do is I have them use the restroom. I collect a urine sample, and then I hook them up to the external fetal monitor, start their IV, get their admission paperwork done, those types of things, so that way when the physician comes, you are ready to administer medications as necessary. If you always ensure that you have that fetal monitoring assessment completed, then typically everything goes relatively smoothly. The physician and you can take a look at that fetal assessment, looking for the variability, looking for the baseline, looking for any accelerations or decelerations. So lots of good information is going to be obtained during that admission assessment of mom and her fetus. Some nursing responsibilities that you may have to be responsible for. If your physician decides to use a forceps, the responsibility that falls on the nurse is just going to be handing those over and ensuring that your physician has everything that they need to have. When we might see forceps used is if at the end of delivery, if mom is becoming tired, she has a fully dilated cervix, the baby isn't rotating in the pelvic outlet, we may see the forceps being placed. And I will bring forceps into the classroom, and we'll discuss these a little more in the classroom. But what you want to be watchful for is that she has to be completely dilated, and they're going to be utilized in the instance of a prolonged second stage of labor. Nursing interventions, again, handing that sterile equipment off to your healthcare provider. Assess for bleeding following the delivery, because it is going to be a traumatic delivery. Not necessarily that those forceps are going to cause trauma, but it is something extra in addition to normal pushing forces of labor and delivery. And then watching that newborn for facial paralysis, any abrasions, bruisings, and it's very common to see some bruising along the side of the head of the baby. You can look at 19.8, that figure in your book, and you'll see a little more information about that. Vacuum extractor is really probably what you're going to be seeing utilized much more so than forceps. With the vacuum extractor, we do not want to see that being utilized before 30 weeks gestation, just to the delayed development that we have of the fetus. So again, our responsibility is handing that equipment off to the provider. The provider will attach the suction cup to the baby's head, and then you will take the end of the suction tubing and attach that to the vacuum portion of the vacuum extractor, and then you will be responsible for applying that specific amount of pressure. You do want to watch for any bleeding following delivery, and then assess that newborn for a hematoma, because you can see from this picture B here on your slide that it does create quite a bit of significant kind of cone head appearance. You also might see a Kiwi vacuum utilized. Works much the same way, but the physician has the control of the amount of force that he or she applies to the fetal head. Prerequisites for a vacuum extractor is complete dilatation. She obviously has to have a ruptured membrane. We want that fetus to have a nice engaged head, a vertex presentation. We do not, however, want to use forceps or vacuum extractors if we suspect cephalopelvic disproportion, and that's just meaning that the baby is too large to come out of the outlet. An external cephalic version. With this is if you have a mom that is in a breech or shoulder presentation prior to delivery. What external cephalic version is gentle, constant pressure on the abdomen, and the idea behind that is that it's going to move the baby into a vertex position. It's always going to occur in labor and delivery and after 37 weeks gestation, because if we do it before 37 weeks, what can happen is the baby can turn into that breech or shoulder presentation again. Before the version, it's going to be our responsibility to obtain consent, do a non-stress test so we ensure the viability and conditions of the fetus. Ultrasound needs to be in the room while they're doing the version to ensure that the fetus is tolerating it okay. We want to start an IV line, and then we're going to administer tocolytics as ordered. Typically, the tocolytic that you're going to be administering is terbutaline, and we give 0.25 ml sub-Q. It's usually 3 stacked doses about 15 minutes apart. The idea behind administering a tocolytic is then to relax the uterus so that it eases the process of the version. During the version, we're going to monitor fetal heart rate and pattern assess mom. Typically, the moms are a little bit uncomfortable during this. It's not the most comfortable things to occur. After the version, obviously continue that assessment, so assessing mom's vitals, the fetal heart rate, watching for any vaginal bleeding, and then administer RhoGAM if necessary. Typically we also have surgery on standby, so that if we would need to move to immediate C-section, we do have that capability. The contraindications are listed out up on this slide for you. They are also listed on page 502 of your textbook. We see external versions being most successful in our multiparous women, so women that have had several babies, because they tend to have a much more relaxed, boggy, larger uterus, and so those are going to be some of the success factors listed out up here as well. A persistent posterior position. When we see a persistent posterior position, what we see is that it's really a prolonged first and second stage of labor, mom typically has a great deal of back pain. Sometimes we're not able to trace contractions, but with a persistent posterior position, the fetus is, as you can see in this picture, the fetus's back is toward the mom, and we see lots of discomfort, things like that. So measures that we're going to utilize to facilitate fetal rotation, having her on hands and knees, having her squatting, having her do lunges, just different things to try to help promote the baby from to move. We also need to talk about a complication called umbilical cord prolapse. With umbilical cord prolapse, what that simply means is that you have part of the cord, as you can see on this picture, coming down either partially through the cervix, completely out the vaginal vault, or hidden maybe up beside the infant. So the idea of this is we want prompt recognition. So it's important that we don't have pressure on the presenting part of the umbilical cord. So the priority is then to relieve the pressure on the cord. And sometimes we're going to have to put our patients in difficult positions to get the pressure off of the cord. But if you should do a vaginal exam and you do feel a cord prolapse, what you need to do is leave your gloved hand in the vaginal area and push upward on the baby's head, call for help, put her in Trendelenburg's or modified Sims, monitor that baby, and if that cord is protruding when your help comes, you need to have the cord wrapped in a warm, sterile soaked towel. We need to move to immediate delivery because this can cause death of the fetus, and vaginal delivery is not going to be possible, so you're going to have to move to immediate C-section. Do not attempt to replace the umbilical cord, just get pressure off of the umbilical cord. And then typically what you will do is you will move to C-section with your patient. You will leave your hand in place and they will put the sterile drapes, things like that, over you. This is kind of another rendition, so if you want to pause the voiceover right now and look at this, it kind of gives a little more in-depth discussion of it. Make sure you're administering oxygen. If you have IVs, then increase that fluid rate because we need to get an adequate amount of IV fluid in her prior to taking her back to surgery. Just take a look at those nursing interventions. Cesarean birth, this is going to be obviously the most common surgical procedure that you will be seeing during labor and delivery. So when you are looking at these, there are indications listed out up here. Oftentimes, if a mom has already had a C-section, she will have repeat C-sections, or she does have the capabilities of doing a vaginal birth after delivery or after a C-section called a VBAC. So a few different things when you're going to be seeing cesarean births. And with a cesarean section, it's obviously just delivering the fetus through the abdomen. So pre-op, remember back to basic concepts of nursing. All of this should be repetition. I'm not going to spend any time talking about it because it is stuff you've already talked about. The only two things differing are going to be to administer the Bicitra and then insert a Foley catheter. Oftentimes with the Foley catheter, those will be placed in surgery unless it's of emergent nature. Shave prep, again, looking at your policy, review what they have, but typically it is a closed leg prep that you will be shaving. Types of C-sections are listed out up here, and I'm going to go to the next couple of screens so that we can talk a little bit about those. So vertical is obviously the up and down that would cut through the abdominal muscles, and your phaneseal, which is most common, is a low-lying or bikini type cut. So those will be your skin incisions. Your uterine incisions are listed out up here. Typically, if you have a woman that has had a classical uterine incision, they probably won't let her do a vaginal birth after delivery because she does have an increased incidence of rupture of the uterus. So that's what we're going to be aware of and be cognizant of. As far as intraoperative care, putting her with a left hip wedge, administering enough IV fluid, and then once the baby is born, you will move into stabilizing the infant, getting the identification bands on, show the patient and her significant other the baby prior to leaving the surgical suite, and ensuring that it's okayed by your physician that you leave the surgical suite, and also that it's okay that her partner is in the room with her. Typically, it has to be a very emergent situation before they don't allow the significant other in the room. We have one more short voiceover to get through, and we will be done with Unit 5.